Good morning, and thank you to the organizing team, especially Dr. Krunal Shah and Dr. Anukul Nikam. So, at the outset, we all know what antimicrobial resistance is. It is a phenomenon where the microbes overcome the action of antimicrobial agent. So, the principle basically is that when a population of bacteria get exposed to the antibiotic, what happens is the commensal bacteria get killed, but those bacteria, those few bacteria which are resistant to that antibiotic, they start multiplying and they start proliferating. And it's not just proliferation, they spread the mechanism of resistance to other bacteria, and this is how AMR spreads. And it is presently a very complex problem because it is not just restricted to human health, but it also is impacted by the antibiotics that is being used in the poultry and also by sewage disposal of the antibiotics by the industry. And that's how the AMR spreads through the water system into the food chain and again impacting the human health. So it is a major complex problem which requires cross-sectoral coordination, and that is the reason why few months back WHO in the World Antimicrobial Awareness Week announced the theme of preventing antimicrobial resistance together with along with the food and agriculture as well as the animal industry. And but the main drive home message is the antimicrobial use itself drives antimicrobial resistance. And in the coming month of September is going to be in history the second ever high-level meeting in the United Nations on antimicrobial resistance. This is so because AMR has been identified as one of the top global threats to human existence. So that's why this meeting at such a high level, which will decide a united policy at government level to combat AMR. Now, we know that if there is multiplication of drug-resistant bugs when you are giving antibiotic, it will lead to antibiotic treatment failure. But it's also important to understand that when it is given to normal flora of bacteria, there is colonization of the multi-drug resistant bacteria which also spread and cause problems. So that is why we keep saying if the antibiotic is not justified, please do not use it because it still harms. And time again, there's plenty in the literature which will tell that the antibiotic itself, use itself, leads to its resistance. For example, you can see cephalosporin use has led to resistance of cephalosporin, then use of carbapenems, again resistance of carbapenems, and now we use colistin for extremely drug-resistant bugs. So as per, just as the cartoon depicts, that it is basically the antibiotics that are the cause of the emergence of the superbugs that we are now fighting with very difficulty in hospital settings. So what is the status update today about antibiotic pipeline? Unfortunately, only 10 new antibiotics have been approved since 2017, and none is from a new class of antibiotics, and therefore the pipeline is just not sufficient to meet the demands of increasing AMR. So the only resort we have is to use the existing antibiotics very, very judiciously. So with this background, I shall now come to the topic that has been given to by the organizers about combating AMR, role of pediatrician in India. Can I have some silence here, please? Thanks. So coming to now, while there are a lot of activities, a lot of actions taking place at in the world, around the globe, we shall focus in India. We know that pediatricians work in different type of healthcare settings, whether it is medical college or corporate hospital, or it can be a district hospital or just a small private clinic. And But what cut across is all these settings is this one single piece of paper. And I think it's not visible for some reason. I don't know, should be some technical problem. But what it had is it symbolized a prescription paper. And it is, if we are going to make any difference individually to AMR, it is by this prescription paper. And why are we listening to this at all on a Sunday in the morning at 9:30 is because how AMR affects me individually is that AMR can kill the patient. It can lead to my treatment failure. It increases morbidity and hospital stay, increases cost for the patient, makes routine procedures risky, and makes complex procedures like transplants, etc., even riskier. And moreover, we are responsible for our future generation. They are already dealing with the problems of climate crisis. It's getting worse year by year, and so is AMR. And we might have a future generation living without the antibiotics with no antibiotics to treat even simple infections. So when we look at the reason why, even if you know it's a viral infection, we tend to write an antibiotic. See, the commonest reason is I don't think it's pharma driven. In majority of the cases, it's probably fear of the unknown. That what if though he's having a viral infection, but what if he's still having some unknown bacterial infection? So let me write an antibiotic as a safety net. So that's the biggest problem that we see. So what I shall be doing in this talk is I shall be talking about very simple, common day-to-day symptoms that patients come and what can be done, when not to use, when to use, and what to write in the prescription and how to manage. And you may think that it is very basic, but unfortunately, this is where the most abuse of antibiotics take place. So OPD. Fever is the most common cause why parents seek consultation with a pediatrician. So if there's a clinical scenario where the child is active and playful in between fever, responsive, at least there is some decrease in the fever when given paracetamol, child is playful in that time, has generalized symptoms like cold, cough, body ache, loose motions, you don't need to start antibiotic. So but then the question comes, and I've heard doctors say, if we don't write the antibiotic, we might lose the patient. And what to write on that paper? So there's a lot of other things to do. And you can explain about the viral fever trend to watch out. And that it spaces out after 72 hours. Maintain hydration. I'm really sorry. Excuse me, I'm getting disturbed by your talk. Please. Sorry. So, maintain hydration. Just ask to report back if passing less urine or if fever trend is worsening after 72 hours. Or if child is lethargic in between fever, and give symptomatic relief. Believe me, there's nothing that's going to go wrong if you do that. And use paracetamol for fever control other than very strong antipyretics like ibugesic or mefenamic acid. Now, if a child comes with cold, and if it's a short duration and it's watery or blocked nose and non-sick looking child, all you need to do is saline nose drops. You can talk about mucus aspirator for young babies. Basically, parents just want to know how to manage that condition. It's not that if you don't write an antibiotic, they won't come back to you. That's absolutely a wrong myth. And you might use even antihistaminics, but that is with caution, especially in young children. If a patient comes with cough and has associated generalized symptoms of fever and cold and are non-sick looking and has wheeze on auscultation, it's most likely to be a viral, where again antibiotics are not required. And especially when, even if there's no fever, but you know this child has intermittent cough episodes in history, especially worsening in the night, you know this is probably a hyperactive airway disease exacerbation. You just need bronchodilators to treat that condition and counsel regarding the cough management. But still, if you feel there are crackles, you're not sure, okay, maybe there could be a bacterial infection, you can still go ahead with an X-ray. If it's showing hyperinflated fields, few bilateral infiltrates, again favoring a viral etiology, you can be well confident of not using an antibiotic. If the child comes with throat pain and if it is associated with cough, cold, there are absence of exudates on examination, presence of any ulcer on the throat. So these are indications of a viral infection. And again, all that you need to counsel is give some paracetamol, ask if in case there is worsening after 48 hours to come back. And sometimes epidemiological background is important. For example, if there is an adenovirus outbreak, flu outbreak, COVID outbreak, you know that probably the throat pain is due to that. And again, they are most of the time viral in nature. If you find spleen on examination, please remember when you are looking at the throat, you need to also do a general examination. And if there is splenomegaly, it's a good practice to do a CBC to look for absolute lymphocytosis or atypical lymphocytes in the smear, which suggest infectious mononucleosis. But again, that's a viral. Now, if a child comes with ear pain and if it's unilateral, less than 48 hours, if the child is above 2 years, there's no systemic toxicity, then you can just find out what's the cause of the earache on otoscopy. Otoscopy is again an important, it is very important part of your examination for ear pain. It could be VACCIID, it could be mild congestion due to a virus, but if the earache persists beyond 48 hours, they need to follow up. So, in case the child comes with loose motions which are watery without visible blood, all that you need to do in your counseling is focus on maintaining hydration, talk about ORS preparations. You may give probiotics, you may give zinc supplementation. Please do not do stool routine if there is no visible blood in such a situation, because what happens invariably is if the stool picks up some 7 to 8 pus cells microscopically or RBCs microscopically, again antibiotics are started based on that report, but that is not so. If it is visible blood, you start antibiotics, otherwise you don't need to check microscopically for the RBCs. Now, for abdominal pain, if the child has soft abdomen without any localized tenderness, guarding rigidity, not associated with blood and stools, no systemic toxicity, there is absolutely no need to start antibiotic, but you need to rule out the cause. It could be constipation, which is very common. It could be gastritis, and manage appropriately. Though it may seem like very basic, but as I said, that's where the antibiotics are most misused. And often children with recurrent pain with underlying cause could be constipation, but a sonography is done which takes few mesenteric lymph nodes and the child is put on a course of antibiotic, but the child comes back because the underlying constipation, which is the real cause, has not been addressed. So now let's come to a situation where when to use antibiotics, because antibiotic stewardship is not about not using antibiotic, but using antibiotics when needed appropriately and even promptly. Now, I'll take the same symptoms, but I'll change the clinical scenario. So if the child is lethargic in between fever, has poor response to paracetamol, poor response to paracetamol comes with a caveat, but with very high fever, viral fevers also sometimes may not show very good response to paracetamol, but you need to kind of go by the clinical signs, other clinical signs about activity, etc., especially in the first 2 days. Check for localizing signs, because that's what indicates a bacterial etiology. And then you need to investigate what could be the cause of that, depending on the signs. So you may start with CBC with smear. And CRP here, I would like to talk about CRP because CRP is widely used, but we must have some caution in interpreting CRP. because even if CRP is say 11 or 15, it can occur in a viral infection. There's no specific guideline which says a specific cutoff of CRP, but generally CRP above 40 is more of a cause of a bacterial, but less could be associated with a viral infection. But again, adenovirus outbreaks have broken all the rules, and adenovirus you can have CRP above 100 also. So these are the situations where you might need to interpret it. Even the WBC in adenovirus can go up to above 15,000. So there are some gray areas, but in general, if a child is dull in between fever spikes, yes, you need to be alert about this could be a bacteria and try to find out where is the problem. So if there is no focus, do a urine routine to check for pyuria. Blood culture is a must if you're suspecting a systemic bacterial infection like typhoid. And as per the clinical clues of history, you investigate for other non-bacterial conditions or dengue, malaria, or rickettsia, leptospirosis. This will depend on the epidemiological situation and the clinical history. X-ray if there is respiratory symptom, or in case of PO, USG for localized signs, and imaging and BM, bone marrow. So that can be a long list. But basically, it is about what tells you in history and what are your clinical signs. Now, if the child comes with cold and it's a long duration, you have purulent rhinitis for over 2 to 3 days. Now here, it is not just simple discoloration of the mucus, because even stagnation of mucus for a day will lead to yellow mucus in the nose. All that you need to do is give saline nose drops to clear. But if there is purulent rhinitis going on for more than 3 days, the long duration cold, there's tenderness over sinuses, child is dull looking, yes. But the antibiotics again is generally amoxicillin or co-amoxiclav and not higher antibiotics for upper respiratory symptoms. For cough, in case the child has localized symptoms where you have localized crepitations and not active in between fever, yes, you start antibiotics, first line could be amoxicillin or co-amoxiclav, cefpodoxim, but do not use levoflox, linezolid, cefixim for an OPD management of LRTI, and above 5 years you might consider macrolides for atypical pneumonia. For throat pain, if there is absence of cough, presence of exudates on examination, tender jugular lymph nodes, the age is between 3 and 15 years. Yes, I'm talking about the center criteria for diagnosing group A streptococcal infection. Yes, you start the treatment with, and we have point of care tests which are very helpful, like rapid antigen test, bedside you can do, and within half an hour you get the report and you're fairly sure before giving a prescription for 10 days. Now here also I've seen in the prescription, like amoxicillin, the dose is actually 50 milligram per kg per day for 10 days. So what usually happens is, now imagine it's a 20 kg child. So it will come to around 1 gram per day. And when you prescribe bottles, it gets over pretty soon, 30 ml bottles. So you can use dispersible tablets which come. Unfortunately, we don't have 500 milligram dispersible tablet, but 250 BD for 10 days. Only in this condition, amoxicillin is given in BD doses. Otherwise, it's given as TDS for Streptococcus pneumoniae. For group A Streptococcus, it's little different, just to alert you towards that. And in case if the systemic examination reveals splenomegaly, as I mentioned before, you need to look out for infectious mononucleosis. Simple CBC is usually helpful. And for ear pain, if it's bilateral, less than 2-year-old child, symptoms are more than 48 hours, or there's systemic toxicity, tympanic membrane is congested and bulging, definitely you need to start antibiotics. And again, amoxicillin or co-amoxiclav, but please use otoscope even at the end of the treatment to see for improvement. Now, in case of loose motions, which there is visible blood in stools, or there is rice water stool, that is the indication to give antibiotic, or if the loose motions are occurring in a sick looking child or immune compromised child. And we usually start these antibiotics for dysentery, cefixim or azithromycin, but again important to maintain hydration. Now, in abdominal pain, if there is localized tenderness or guarding, then definitely you will go for ultrasound as first investigation to rule out any sort of pus collection, whether it is liver abscess or appendicitis, and surgical emergencies have to be ruled out at that time. And if there's disproportionate tachycardia with board-like rigidity, these are red flags of danger. Now, coming to pain on micturition, if the clinical scenarios of along with fever, but please remember adolescents with mild cystitis may not have fever. So that is something to be remembered. And also when children come with just pain on micturition without fever, it's important to also look for vulval rash, because I've had children who have had repeated courses or thinking it's a urinary tract infection, repeated courses of antibiotic, but actually they have the vulvovaginitis, which causes burning when the urine comes in contact with the skin. So all that is needed actually is zinc oxide paste application and keeping the area dry. But if in doubt, always send urine for look out for pyuria, and if it is confirmed, definitely send culture before you start antibiotics. And I'm sure there's a panel on diagnostic stewardship which will talk about proper collection and of the sample, which is very important to interpret the report. Now, after talking about very day-to-day clinical scenarios, I'm sure that if we follow this, if at least 40 to 50% of inappropriate antibiotic use will go down. Now let's look at inpatient settings. What is important is again urgent antibiotics if you're suspecting sepsis or a sick immune compromised host, because the antibiotic should go in within 1 hour. That's the golden rule. And give broad spectrum antibiotic, but please do send blood culture before you start that broad spectrum antibiotic. Now, just because you're admitting a child for dengue or for uncomplicated malaria, flu, or maybe acute gastroenteritis with dehydration, it does not mean you start antibiotics. So antibiotic indication is not about admitting your child to the hospital. So please do not do that. And also based only on Vidal positivity, do not treat typhoid. This has been repeated multiple times in various conferences. Please do send blood culture, because just 2 months back, there was a child who had full courses of enteric treatment 4 times in the year just because Vidal was positive every time. Avoid treatment of colonizers or contaminants like corns. So that's another big problem in ICUs and hospital settings where unfortunately they are treated. Beware of thrombophlebitis as a cause of secondary fever before escalating antibiotics. Because what happens in generally is that the child is on some antibiotic and then suddenly the child starts spiking. So the child came with an admission of 101 fever, but suddenly the fever starts spiking on day 3, day 4 to 103, 104. There is panic. Investigations are sent all over again. CRP comes much higher than what the child had come with, and you think that it is a very dangerous drug-resistant bacteria, and it is antibiotics are escalated straight to very high antibiotics. So that should not be done if there is clear evidence of thrombophlebitis. So this is a very common mistake done even by the best intensive care units. So please remember, CRP will be raised if there is thrombophlebitis. So look for thrombophlebitis. That could be a cause. All that you need to do is remove the IV line and manage the thrombophlebitis, and the fever starts coming down in a day or 2. Source control is essential whenever you're treating infection, whether it is empyema, you need to drain the pus for the antibiotics to work. In patient settings, you discuss daily in the rounds, even if 1 day extra of IV is needed, ICD is needed, whether central line can be removed today, whether catheter can be removed today, that discussion should be part of the rounds. De-escalate antibiotics whenever there is an opportunity. Switch to oral antibiotics when stable, able to tolerate orally. There are exceptions like meningitis, endocarditis, or neonates where you cannot switch to oral. Infection control is crucial, especially hand hygiene. Child, if not improving, despite the antibiotics which you think are the right ones, it could be wrong antibiotic, but it could also be a wrong diagnosis. It might be a non-infectious cause like SOGI, malignancy. It could be anything else. So you need to revisit the diagnosis. Now, after having explained all these tips, it is very important for me to inform you about what is going on across the world. The WHO has classified all the known antibiotics into 3 categories: access, watch, reserve. Access are those antibiotics which have the least potential to develop resistance. So these are all the ones which we usually use in our OPD practice, like amoxicillin,
You
co-amoxiclav, the
have
first
five
and
more
second
minutes.
generation cephalosporins. The watch are those which have high potential to develop resistance, like third generation cephalosporins, carbapenems, macrolides, piperacillin, tazobactam. And reserve are those which are to be used only if there is no other alternative as a last resort, like colistin, tigecycline, linezolid, etc. And it is on basis of this access watch reserve that consumption of antibiotics between countries are also compared. This is, for example, one in Lancet which was published, and you can see India on the top, where the consumption of access is around 30 to 30%. And what is required is at least 60% of the greens for all countries. We will know in September what decision is taken, but they are going to pull up the government if the consumption is different. And we have resources, so we can use these metrics for our OPD practice also, more of greens for OPD especially, so you can know last resort antibiotics for in OPD practice unless really justified. But we have various resources at fingertips, and all these resources are there, very good apps. We have websites like Up to Date. Please do refer to, and also we have small academic groups. You can ask questions. We are more united than before. You can reach out to any expert if there is any problem that you're facing. And we tried this WhatsApp tip of the day, which was well received. And I think, WhatsApp is also, WhatsApp University, though criticized, if good information goes in, it is helpful. I was honored to be part of the policy statement of another country, but as I work with all those people, I realized that policies or guidelines can change with time or slightly differ between themselves, but at the same time, the principles of treating an infection, which I talked today, generally by and large remain same. Even if after 15 years, it will remain same. So please think about that. Do not hesitate to discuss or investigate or report unusual observations. At least write a letter to the editor. There were few cases of ceftriaxone and resistant Salmonella typhi, but it's still not in Gujarat, but still it's not there in the literature. Let it not be lost with time. The newer generation needs to know. And I just have 3 slides. So this is just as a motivation. In 2017, I wrote a letter to Dr. Soumya Swaminathan, who was ICMR director at that time. I didn't know her at all, and it was not through any personal connection. Just wrote that we are seeing a group A streptococcus outbreak in our city. She immediately put the ICMR into action, and that led to India's first genomic report of group A streptococcus database. So this is what, you can just reach out to public support, and that will help everybody. So coming to the last slide, that the prescription is what can change. When you put weight, clinical history, also talk right after, apart from supportive treatment, do you really need to ink that antibiotic? And if yes, put it in the right Ds. Right diagnosis might be very difficult, but right drug, dose interval, duration, and please spend time counseling. Also the use of antibiotic, how are you going to reconstitute it, how are you going to store it in the house, in whether you're going to refrigerate, whether you're going to give after meal, all that is important. So be the change you want to see in the world. Thank you for patient listening.